Random House Audio presents The Anatomy of Hope, How People Prevail in the Face of Illness. This is the author, Jerome Groopman. While all of the incidents in this book are true, the names and personal characteristics of the individuals involved have been changed in order to protect their privacy. Any resulting resemblance to other persons, living or dead, is entirely coincidental and unintentional. Why do some people find hope despite facing severe illness, while others do not? And can hope actually change the course of a malady, helping patients to prevail? I looked for the answers in the lives of several extraordinary patients I cared for over the past 30 years. They led me on a journey of discovery, from a point where hope was absent to a place where it could not be lost. Hope is one of our central emotions, but we are often at a loss when asked to define it. Many of us confuse hope with optimism, a prevailing attitude that things turn out for the best. But hope differs from optimism. Hope does not arise from being told to think positively, or from hearing an overly rosy forecast. Hope, unlike optimism, is rooted in unalloyed reality. Although there is no uniform definition of hope, I found one that seemed to capture what my patients had taught me. Hope is the elevating feeling we experience when we see, in the mind's eye, a path to a better future. Hope acknowledges the significant obstacles and deep pitfalls along that path. True hope has no room for delusion. For nearly 3 decades, I have practiced hematology and oncology, caring for patients with cancer, blood diseases, HIV, and hepatitis C. I have also labored in my laboratory, studying the genes and proteins that these disorders derange. During much of that time, at the bedside and at the laboratory bench, I failed to consider the impact of hope on my patient's illness. Yes, I gave the customary nod to it, but then I would focus squarely on interpreting their laboratory reports, reading their CAT scans, and studying their biopsies. All essential to diagnosis and treatment, but incomplete. Personal experience opened my mind. For some 19 years after failed spine surgery, I lived in a labyrinth of relapsing pain and debility. Then, through a series of chance circumstances, I found an exit. I felt I had been given back my life. I recognized that only hope could have made my recovery possible. As a scientist, I distrusted my own experience and set out on a personal journey to discover whether the energizing feeling of hope can, in fact, contribute to recovery. I found that there is an authentic biology of hope. But how far does it reach? And what are its limits? Researchers are learning that a change in mindset has the power to alter neurochemistry. Belief and expectation, the key elements of hope, can block pain by releasing the brain's endorphins and enkephalins, mimicking the effects of morphine. In some cases, hope can also have important effects on fundamental physiological processes like respiration, circulation, and motor function. During the course of an illness, then, hope can be imagined as a domino effect, a chain reaction, in which each link makes improvement more likely. It changes us profoundly, in spirit and in body. Every day I look for hope, for my patients, for my loved ones, and for myself. It is an ongoing search. Here, I tell what I have found. In July 1975, I entered my 4th and final year of medical school at Columbia University in New York City. I had completed all my required courses except surgery, and was eager to engage in its drama. Surgeons acted boldly and decisively. They achieved cures, opening an intestinal blockage, repairing a torn artery, draining a deep abscess, and made the patient whole again. Their art required extraordinary precision and self-control, a discipline of body and mind that was most evident in the operating room, because even minor mistakes, too much pressure on a scalpel, too little tension on a suture, too deep probing of a tissue, could spell disaster. In the hospital, surgeons were viewed as the emperors of the clinical staff. Their every command obeyed. We students were their foot soldiers. I was intoxicated with the idea of being part of their world. The surgical team I joined was headed by Dr. William Foster. Foster was a tall, imposing man with sharp features like cut timber. His rounds began at dawn, followed by 2 or 3 surgeries that lasted until late afternoon. As is typical in a teaching hospital, all of Dr. Foster's patients were assigned to medical students who learned the basics of diagnosis and treatment by following cases. Not long after I began the course, I was designated as the student to help care for Esther Weinberg, a young woman who had a mass in her left breast. Esther Weinberg was 29 years old, full-bodied, with almond brown eyes. She was a member of the Orthodox Jewish community in Washington Heights, the neighborhood adjoining Columbia's medical school. When I entered her room, Esther was lying on the bed, reading from a small prayer book. Her head was covered by a blue kerchief, in the typical sign of modesty among married Orthodox women, whose hair, as a manifestation of their beauty, is not to be seen by men other than their husbands. "I'm Jerry Groopman, Dr. Foster's student," I said by way of introduction. I wore the uniform of the medical student, a short, starched white jacket with my name on a badge over the right breast pocket. The badge, conspicuously, lacked the initials M.D. Esther quickly took my measure, her eyes lingering over my name badge. I did not reach out to shake her hand. Men do not touch strictly Orthodox women, even in a casual way. Esther's eyes returned to my name badge, then to my face. I guessed at what was crossing her mind. Whether my not shaking her hand indicated that I was Jewish and knowledgeable of the Orthodox prohibition, or simply an impolite student. Groopman was Dutch in origin, not a giveaway. Dr. Foster had described Esther as anxious, and I felt that disclosing our shared heritage would put her at ease. "Shalom Aleichem," I said, the traditional greeting of peace be with you. Instead of offering a welcoming smile, her face drew tight. Following protocol, I began the clinical interview, which includes taking a family history and social history. Esther Weinberg, née Sigmund, was born in Europe in 1946. Her family was from Leipzig, Germany, and of its more than 100 members, only her parents had survived the Nazi camps. The Sigmunds immigrated to America in the early 1950s. Esther married at the age of 19, had her first child, a girl, a year after the wedding, and then twin girls 18 months later. Her father died of a stroke not long after. Over the last year, she had worked as the personal secretary for the owner of a cleaning service in Midtown Manhattan. Her job was strictly clerical, without exposure to toxic solvents that can be carcinogenic. One of the primary risk factors for breast cancer is a family history of the disease. Esther had limited knowledge of those who had perished in the war, but she recalled no afflicted relatives. Another major risk is prolonged and uninterrupted exposure to estrogen, which occurs when menarche, the onset of menses, happens at a very young age, or when pregnancy occurs later in life or not at all. But Esther had entered puberty at 13, a typical time, and carried and nursed 3 children in her 20s. This early motherhood would, if anything, lower her risk for breast cancer. I conducted the physical examination that I was taught to perform specifically on women, to convey a sense of propriety and respect for their body. I covered each breast in turn as I palpated for irregularities. I was taken aback by what I found. The mass in her left breast was very large, about the size of a golf ball, easily felt above the nipple. There were many lymph nodes in the left armpit, also large and rock hard.
Sample complete. Ready to continue?